Hi, I'm Lacey Shumway. I am the Coverdell Program Manager with the Regional Extension Center at the University of Kentucky. Today, I want to go over just a bit of what we are aiming to do with the Coverdell grant. We are a CDC-funded grant. We are good for 3 years. We are actually working in our year 3, which will take us into June of 2024. We are one of 13 states. Lucky enough, we are unique in the sense that our award was awarded to us at the University of Kentucky. We have partnered with the University of Louisville and the Department of Public Health. The 3 of us went in on the grant and luckily were awarded. So we are very lucky to be working off of groups that were already in existence prior to us being awarded the Coverdell grant in 2021. The Kentucky Heart Disease and Stroke Prevention Task Force, which is a group under the Department of Public Health, and CEQIP, which is a Stroke Encounter Quality Improvement Project, which consists of the certified stroke centers across the Commonwealth, have been working together dating back to 2006 to improve stroke care in Kentucky. And between the University of Louisville and the University of Kentucky and the Department of Public Health, we thought it was the next best thing to apply for the Coverdell grant to further those efforts that have been ongoing for almost the last 20 years. So we are lucky enough to work with multiple healthcare systems across Kentucky and community providers like community health workers, federally qualified health centers, PCP offices, and we are focused mostly in high mortality counties across the state. And we have created the Kentucky Stroke Improvement Cooperative, which is our big leadership group that oversees all of the work that we do with the Coverdell grant. So we have a number of strategies that we are currently working on. Number one, with our federally qualified health centers and our PCP offices, we ask them to utilize their EHRs to identify those high mortality patients within their practice that have the highest risk for stroke. And we identified that highest risk as those with hypertension who have a reading of 140/90 or greater. So they are doing what is called the Care Collaborative with those patients, which is a learning encounter that takes place between a coach and a individual. So that coach may be the nurse, a tech within a practice, the doctor, but they help the patient understand what their blood pressure is, the impact it can have on their overall health, and if they are identified as having hypertension, they are given lifestyle modifications to work on to help lower their blood pressure. So we do have all of the certified stroke centers in Kentucky, with the exception of 2 that are currently working with us. So that puts us at 36 total hospitals who signed an amendment to overlay onto their Get With the Guidelines stroke account to share their data with us. Then we also have a data sharing agreement with the Kentucky Board of EMS to receive monthly data dumps of all of the run sheets from potential stroke runs across the state. And then we are working with a biostatistician on our team to make the match between those Get With the Guidelines stroke patients and our run sheets from the Kentucky Board of EMS. We have hospitals working to set up referral tracking systems within their hospital to identify those patients that are going home, or maybe who went to rehab but then might need some assistance after they get home from rehab, so they can make sure that they meet their doctor's appointments if they need any assistance filling prescriptions or getting to a social service within the community. They're getting those referral systems set up and in place at the hospitals that we're currently working with. We have hospitals and EMS working on quality improvement initiatives, and we'll briefly go over what those look like here in a moment. We have set up a community of practice where we are developing workforce development opportunities for those hospitals in the state who are not certified in stroke. And through that, we have helped create a webinar series around recognizing implicit bias in the healthcare worker, and you'll see a flyer for that here in a moment. And then we are working with CHWs across the state of Kentucky to follow up with those patients that have had a stroke that go home, and helping them also do the Care Collaborative. So again, identifying those hypertensive patients and recognizing that there are some lifestyle modifications that can be made for those patients to prevent having another stroke. Just a little overview of what the stroke mortality rates here in Kentucky look like. You'll see multi-shades of blue on your screen. The darker the blue, the higher the stroke mortality. And you'll see that those areas are really focused in the eastern part of the state, the southern, south central part of the state, and then over in the western part. So we have a lot of work ahead of us, but we are slowly making impacts across the counties that you'll see in this map. So I mentioned that we are matching our pre-hospital run sheets to our confirmed stroke patients that are put in to get with the guideline stroke. So that started in 2021. And our biostatistician has done a phenomenal job in getting these matching rates to be where they are. You can see that we ended 2021 almost at 82% matching between the pre-hospital run sheet and the chart from Get With the Guideline Stroke. In 2022, we ended just slightly lower than where we sat at 2021. We did have 2 months where we dropped significantly. We still have not been able to identify what the trigger was to drop that percentage, but again, we ended 2021 at almost 79% match rate. And in 2023, you see we currently sit at about 77%. These numbers fluctuate because our hospitals do retroactively abstract their charts. So some of them are anywhere from 6 to 8 weeks behind on their abstraction. So those numbers that you see in April, May, and June will continue to go up as we do our monthly data pulls to do the matching. Just an overview of the quality improvement activities that you see our hospitals and EMS are working on. You'll notice the very first one listed for the hospitals is door in, door out. Now that is a time that is supposed to be under 120 minutes, and it is measured by when a stroke patient arrives at one hospital and they are discharged out of that emergency room to go on to a higher level of care for definitive care. Now, the goal is 120 minutes. We are not currently meeting that measure very well across the state. So us at Coverdell, CQIP, and the Stroke Care Network, we are all working on the same measures and goals to get hospitals all under that 120 benchmark, 20-minute benchmark. You can see that hospitals are also working on a number of other quality improvement activities. We allowed them to pick things that were going on within their stroke programs that they felt needed improvement to kind of get their feet wet before they really jumped into the deep dive that is improving door to needle and door in, door out times. Now you'll notice communication is both on the hospital and EMS list. EMS is very involved in the door in, door out times here in Kentucky, but we also are working on documentation of where they put certain things in their run sheets can improve upon our match rates, but also show that, yes, in fact, they did call ahead when coming into a hospital with a stroke patient. Just an overview of some data that we do share with our hospitals and our EMS partners. And we share this because we can directly correlate that when an EMS provider calls ahead to the receiving hospital and documents it, that there is a decrease in time of door to CT and door to thrombolytic. You'll see that there is a difference of about 10 minutes on the time they receive a thrombolytic if there's a call ahead compared to not having a call ahead on the record. So we have used this to recruit EMS agencies into our ongoing quality improvement work. Look at the map of certified stroke centers compared to the non-certified centers. So the multiple colors you see on this map, those are our certified stroke centers. So the pinks and the greens and the purples and the yellows and those and reds, those are our certified stroke centers. Now the lighter color, kind of bluish purple, those are our non-certified centers in Kentucky. And those are the hospitals that we identified through a survey that said, yeah, we would like to know more about how we can improve upon our stroke care and our emergency department. So Those hospitals may be just small critical access hospitals, or they may be a small community-based hospital that is not associated with a larger system. So as you can see, we still have a large number of counties that don't have hospitals. So increasing access to care through helping those smaller hospitals is one of our biggest goals. Now, I mentioned prior that we have worked on doing education around recognizing implicit bias among healthcare workers. We were lucky enough to partner with a group called Wellness Equity Alliance, and they're a public health company whose goal is to put out education specifically around implicit bias among healthcare workers. So we have marketed this to every hospital, EMS agency, for any practice that we are currently working with, and it is free for users to view. It is a 9-part on-demand webinar series. If you scan that QR code on your screen, it will take you to the registration. These webinars are good until August of 2024. And again, they are free, and you can earn CE credit if you register with your titles, whether you're a nurse, you're an EMT, a paramedic, a doctor, a PA, a CHW, you can earn CE credit through this webinar series. So thank you for taking the time to listen to the work that we have ongoing with the Coverdell grant. If you heard something you would like to learn more about, you're welcome to send me an email at lacey.shumway@uky.edu, and I look forward to speaking with you.